Welcome to Heroic Herstories, Women in Medicine with the Katies. This podcast is to document the stories of women trailblazers in medicine in the state of Iowa. We will highlight seasoned women in medicine to create a brief oral history of their works and lives. We want to learn from their experiences, share their vast knowledge, and gain insight into the challenges they have faced. Our goal is to lift up those who have gone ahead of us and thank them for their incredible service and dedication in our wonderful field.
Today, we are welcoming Dr. Vicki Kijewski. Dr. Kijewski, how would you like us to address you today? What do you want us to call you?
Vicki's fine.
Vicki. So Vicki graduated from Truman State University in 1984 with her bachelor's in education. From her CV, we can tell that she later went on a tour of the Pacific Northwest and graduated with a master's in education, specifically mathematics, in 1990. Katie and I are out of our league already. And we're curious to hear how she was spending her time in between degrees, so we'll come back to that. She spent time in Idaho before returning to Kansas to complete pre-med classes and then attended medical school at the University of Missouri-Columbia College of Medicine and graduated with honors in 1998. She then completed a 5-year combined residency in internal medicine and psychiatry here at the University of Iowa in 2003 and was a chief resident in the program. She's remained here on staff at the University of Iowa in both the internal medicine and psychiatry department and has been the definition of a leader and educator here. She has been the director of our locked medical psychiatry unit, which very few institutions have, since 2003, the program director for the internal medicine psychiatry residency program for many years, and has won just about every teaching award possible, many of them multiple times. She's a constant resource to all of us needing help with medically and psychiatrically complicated patients in the hospital and a real inspiration to all of us. We're so happy to welcome Vicki to our podcast today.
Thank you. Thank you.
Welcome, Vicki. We're so excited. As you know, Katie and I are real investigative journalists, and we like to ask the hard-hitting questions first, just to keep you on your toes. So we noticed that you've moved around a little bit in the Midwest, Pacific Northwest, and both of those places have some very fun dynamic weather patterns. And we love to ask our guests, if you had to describe your personality in terms of a weather forecast, what's the forecast?
Overall, I think I'm pretty calm and even keel, sunny weather. Every once in a while, though, there's some thunder snow that happens.
Thunder snow.
Thunder
So
snow.
cool.
Yeah.
Rare and amazing when it does happen.
Well, it could be
Terrifying,
amazing
too.
unless you're on the other end of it. If you're on the receiving end, maybe not so amazing.
I'm going to try to stay out of that forecast part. I'll try to stay on
Yeah.
the sunny side. Yeah. Wonderful. Okay. Well, then we know where we are, and we're hoping for no thunder snow
We
during
know
the talk
what
today.
to watch out for.
Yes, exactly. Yeah.
So, Vicki, in reviewing your CV, which is common among many of our trailblazing women, we saw that you didn't really have a linear path to medicine. Can you tell us about your life before medicine and how that led you to choose to go into medicine?
So that's a great question. I never planned to go into medicine. Both of my parents are teachers, and my dad was a coach, so I just figured that I would like teach and coach. And my graduate degree was in mathematics, education, and then ever since I was in 7th or 8th grade, I had always wanted to go to the Peace Corps. So as soon as I was done with college, I went to the Peace Corps. So I was in Nepal for a couple of years, and I was teaching math and science there. Um, while I was in while I was in Nepal, they had given me 2 books. One was in English and one was in Nepali. It was called Where There Is No Doctor or Doctor No Bayeko, which they were the same book. It was just, kind of a resource, like, Peace Corps volunteer, treat yourself if you're sick, or, um, and, sometimes people in the village would come up to me and ask me questions, and I'd be like, I have no idea what is wrong with you. I have no idea what this rash is. And, this was in the 1984, 85, 86. So it's not like there was internet or anything that you could look at. So I would flip through the book. Um, but I still didn't have really any desire to go into medicine. But after I got back to the States, I worked for Eddie Bauer for a little bit. And then I decided to go back to school and get a master's in math because I was going to teach math again. And then I taught math for a little while in Idaho and then back down in Kirksville, Missouri. But this kind of this seed that had been planted about medicine, um, I kept still thinking like, well, should I go to medical school? And then I was like, there's just no way that I'm gonna go back to school again and, like, get a biology or chemistry degree. I thought I had to have one of those. That's how, like, uninformed I was. And then I just started looking to see, like, what prerequisites I needed, and I had quite a few of them, but I really hadn't had much biology or, biochem, but I had so I needed, like, I think, a couple of biology classes and then a biochem class before I could, like, take the MCAT. I was teaching at Truman State at the time, um, and so I did my prerequisites, and can you imagine? I was teaching calculus at the time, so I had a Calc 1 class, and unfortunately for one of my students, she was my lab partner in biochemistry. And I can just tell you that I was probably not the best biochemistry lab partner to have because more experiments went wrong than went right.
I'm just imagining, like, me being in college and being like, and my calculus teacher is now my lab partner. That's
Somebody got the
makes me
short end of the
nervous.
stick.
It would feel like you'd have to give some points back in calculus in order to make up for the biochemistry
That might have happened,
issues.
Katie. Yeah, it probably
Wow.
did happen actually.
Balance the books.
Well, I was gonna say that's a lot of like juggling of stuff. Like you're
Mhm.
teaching, you're going to school. Like, that's a lot to do. That's amazing.
Yeah, but I was only taking I was only taking one class semester, and I really didn't have that much in terms of prerequisites that I need to finish because, I already had, a year of physics and a year of regular chemistry, like, way back, earlier.
Mhm.
Wow.
What
Okay.
was the most gnarly thing you taught out of your I mean, you cured from your book, your medical book when you were in the fall?
Um, there it was a lot of, like, a lot of infectious disease, and there wasn't a doctor, but there was, like, a pharmacy, and you didn't have to have a prescription, so it was like, you know, I don't know if this is the right antibiotic or not, but maybe see if they have, whatever, amoxicillin or something at the pharmacy.
Do you still have that book with pictures of rashes? Because I could use it.
Yeah. And I don't know which antibiotic to use either, so
Oh my gosh.
amoxicillin is always my first choice.
Yeah.
Uh, so, I mean, before you went back to medical school, then you kind of already had that experience of kind of being quote unquote a non-trad, right? Like having other life experience. Like how was that transition? You're teaching at a college level and now you're going back to classes with all these people.
Yeah, I mean, fortunately, I went when I went to medical school at the University of Missouri, there were probably 4 or 5 other, students in the class that were in their
Mhm.
30s as well, but, yeah, the rest of them were, 22 or something.
Yeah. Yeah.
So it was hard, I think, just I'd like to be in control, and I think when you're a medical student or a resident, you can't be in control, and I had been used to, like, being in control of my time and, you know, what I was doing when and if I was gonna take a vacation or something like that.
Yeah.
Yeah, I think that's the part of medical training that you can only put up with if you've not had an actual life before you
Mhm.
do it, like, I think the, utter lack of any control over your schedule or choosing how you spend your weekends or, basic adult things. If you've never had that, it's a lot easier to stomach. But if you have, I think that's why I feel like all like the folks who've been around the block and then come back to medical school are always like, ugh, this is hard. And I agree. I think that's like a very difficult part of it.
Well,
Yeah.
it's for a protracted time too,
Yeah.
right? Like you have like your 4 years of medical school and then you had 5 years of residency. Like that's a long time to be like, I still don't have control over my schedule.
Right.
Yeah, that's a challenge.
And so Katie mentioned 5 years of med psych residency. So at that, I would be guessing that in the late 90s, that was not a commonly available residency program. And what made you choose medicine and psychiatry combined?
You know, that's it. My very first clinical rotation as an M3 was internal medicine, and I fell in love with internal medicine. I loved going to morning report. I loved noon conference. I loved like sitting around, thinking about like the patients and the cases, pulling up like, I had Cecils and Harrisons, and I would, oh gosh, I'm trying to put this together. What could it be? I love the detective. I know you two are big detectives, but I really love the
Journalists.
detective work of internal medicine, and I just had some great attendings great patients that really let you like talk to them and try to figure out what was going on. So that was my very first rotation of my 3rd year. And then my last rotation of my 3rd year happened to be psychiatry, and it was similar and yet so different, right? It's a different language, it's a different way of interacting with patients, but it still is like really talking to patients, learning their story, trying to do the best job that you can possibly do with understanding their life situation. And so um I was like, "Oh, I really like psychiatry," but, every time a patient comes in with a medical problem, whether it's like diabetes or high blood pressure or an elevated TSH, we're just like, "Oh, yeah, you're gonna have to see your primary care doctor about that. We're not gonna take care of that right now. You're in here for depression, or you're in here for a episode of mania. We're not gonna worry about these things." And I was like, "Well, this doesn't seem right, because a lot of these patients don't have primary care doctors, or maybe they have them, but they're like me, they don't like to see them, you know?"
That's fair.
And
Right.
and so I couldn't decide, and then, do you remember back in the old days, you had to, like, look through a book about all the residency programs that were available?
Mhm.
And
Yeah.
then when I was flipping through the book or the pamphlet, whatever it was, then I saw, oh, there's these internal medicine and psychiatry programs. And then also, as a 4th year medical student, I came up here and I did, a visiting sub-internship on the med psych unit, which used to be over on 4 Southeast. And I had the 2 interns I worked with. Marta Van Beek was one of them. She's a
Yeah.
she's
Yeah.
a dermatologist. And then Chris Okishi, I don't know if you know him. He's a psychiatrist in town.
Mhm. Yeah.
But those were the 2 interns that I worked with when I was doing my sub-I, and oh my gosh, they were so welcoming, they were so fun. We just had the best month ever, and the patients were so cool.
Wow.
The
So
culture really matters, right? When you're choosing a medical specialty, which is kind of interesting to think
Mhm.
about how much that impacted your life when it really was not necessarily like a rotation that you went in intending to choose a career based on it, but it really captured your attention.
Mhm.
just out of curiosity, did you work with any dual trained med psych doctors during your
I
Sigma?
During that sub-I
Mhm.
worked with Roger Cathall. He's kind of the he was kind of like the father of med psych in our institution.
Okay.
So I worked with him for a bit up there.
Okay. Well, I was just, I was curious because then, this is kind of, I would say it's still kind of a lesser known subspecialty, but you
Mhm.
then decided to apply to this 5-year residency program. And can you just tell us a little bit about this? Because, being on the residency side, I see these residents, moving from psychiatry and then internal medicine and then psychiatry. And just tell us a little bit about that because that looks really hard.
I mean, I think in a lot of ways in a lot of ways, I do think it's hard. Typically, people do like 30 months of internal medicine and 30 months of psychiatry, and that fulfills the requirements. I mean, you don't have as many electives or selectives as other people would have, and the way that we do it at the University of Iowa typically is, the first 8 months, people are in internal medicine, and so when you start and it's those first 8 months, like, you're on a level playing field with you know, with the rest of the interns. You all started with the same place, and then the last 4 months I went to psychiatry then, during the last 4 months of my intern year, and I was like, Gosh, I know nothing here,
Yeah.
and and then, we do try to split it up though. Like I said, the first year is about 8 months of internal medicine, um, 4 of psychiatry, and then mostly it's 6 and 6, except during the 3rd year, we usually just do 4 months of internal medicine and then put people into their psychiatry clinic year that lasts 12 months. So I think the biggest challenge is just trying to tell yourself that at the end of 5 years that you will be a great internist and a great psychiatrist, but you have to have patience because, even though you started at the same place with the interns in internal medicine, when you come back to internal medicine, you're like, "How did everyone get so smart?"
Yeah. Yeah.
And what happened to me and everything. And then the same way with psychiatry, you're like, how did people learn all this stuff? I wasn't gone that long, but it all I mean, I think it all evens out. I'm so happy that I did it. I wouldn't have done it any other way.
Do you find yourself with like, I find myself constantly saying to students and residents, like, trust the process. Like, because there is so much of that, just like, what? Like, I'm going to get there
Yeah.
in X number of months? That's impossible, Oh,
I remember my mind was blown by the senior resident who was on my medicine clerkship when I was a student, which is
yeah,
also what grabbed me for internal medicine. But like I was like, she just felt omniscient.
yeah,
Like
yeah.
anything that happened, I would go like stand outside the GI endoscopy suite waiting for my patient to come out. And they'd be like, I would know exactly what happened. And I'd run back and she's like, yeah, I know. I'm like, well, I was there and I like ran here. I'm sweating. See, I'm sweating. And she was like, yeah, they paged me. I'm like, God, yeah.
The
But
pager again,
right.
Yeah.
please.
And so
Now it's
I'm
time.
always telling students, I'm like, it just like once you go through it, you have like a mental like framework where you can hang all this information. It just stays in your head easier. But I imagine doing that for both medicine and psychiatry does feel like a huge cognitive load for the residents, especially when they're in that like second and third year kind of doldrums. They
Mhm.
can't remember being at the beginning and they can't see the end, and that's got to feel like a lot.
Yeah, and then in the old days when the R2s were matching into fellowship already at
Mhm.
that time, and
Yes.
you're like, "Oh my gosh, they
I'm not
already
even
have matched."
halfway.
Yeah.
Yeah, that's overwhelming.
Yeah.
Amazing.
And so, because a lot of that time that they're spending is just sort of gaining expertise and taking care of these very complicated, because they're going to be expected when they come out to take care of the medical complexity of an internist and the psychiatric complexity of a psychiatrist.
Mhm.
What sort of experiences do you have that really highlight what that's about from a dual trained person? Like, are there any patients that you can think of that are good examples of that?
I can think of a couple of patients that you know, that really made me so glad that I was both an internist and a psychiatrist. One of the one of the patients had been diagnosed with burning mouth syndrome, and she had seen like so many people, ENT, dentists, oral surgeons, neurosurgeons. Um, she had just seen so many people, and she was just miserable. Somehow she ended up on the I think she ended up on the med psych unit. I think it was for a second opinion. And I mean, I know she had burning mouth syndrome. There's nothing I know that she had that, but then, we also noticed that she had a really bad depression with psychotic features, and she took a chance on us because we wanted to treat her with electroconvulsive therapy, which I think a lot of times is really scary for people. But she took a chance on us, and we treated her with ECT, and everything got better. Her depression
Mm.
got better, her burning mouth syndrome got better. This is a woman that had all of her teeth taken out. She was eating only a liquid diet. I mean, she was like there was no doubt that she was just suffering.
Mhm.
Yeah. Yeah.
And, I think that was one. Another one that comes to mind, I think most people now know about NMDA receptor encephalitis, but this was earlier on, and this woman that had been pretty functional now all of a sudden isn't functional. She seems to have, you know, behavior change, auditory and visual hallucinations, cognitive decline, and ended up having NMDA receptor encephalitis, ovarian teratoma. Got treated with the usual things like you know high dose steroids, IVIG, plasmapheresis, rituximab, and it was a really long journey, and I know it wasn't like comfortable for her to be in the hospital, but those two, y- you know, those two patients just, make me so glad that I did my training here in Iowa, and that we have this med psych unit where, I shouldn't say this out loud because somebody's going to hear it, but
There's only
I
gonna be
think it's
7 people
harder.
listening to
It's
this.
like harder to pressure me to discharge somebody from there. I'm just like, yeah,
Yeah.
I'm not ready.
Mhm.
I'm not ready. Can't do it.
Yeah.
Yeah.
Well, Vicki, as a person who often calls you in the hospital, I'm also incredibly thankful that you trained and did all of this because it really like I'm calling you when I'm like, I have no idea what to
Yeah.
do. Like I don't know. I need help. And it's just I feel so grateful that you're here so that I can call you for that help. I'm always worried I'm annoying you, but thank you
Never,
for your help.
never.
Well, and it sounds like the patients that you're describing, like, what kinda ties them together is that, it seems like in your practice where you're sort of being in both of these worlds, a lot of what you have to do is work something up in a thoughtful way in order to validate and also at the same time validating the patient's symptoms, but working it up to the extent where you're making sure you're not missing anything, but then working back around to the psychiatric components because
Mhm,
in my experience with these types of patients, a lot of the time is spent laying the foundation that there may not be like organic pathology here. It may be something that is a psychiatric complexity that needs to be managed. And people are like, oh, you think it's all in my head? And it's like, no, I think you're having your problem, but it seems like you are really ideally positioned to straddle that and talk with people about how, their mental health symptoms can affect their physical health and vice versa.
mhm. Yeah, thank you.
I was just curious. I might be freestyling a little bit, but
That's okay.
but internal medicine is hard to keep up on. Psychiatry is hard to keep up on. How do you do this? Like, how in the world do you do this?
I, so I think I might be just, like, I'm always trying to, like, read something or listen to something. I try to go to grand rounds. I try to go, grand rounds in internal medicine, grand rounds in psychiatry. I really use the, video recordings that ACP has. I do a lot of those. I do consult guys. I try to do, like, in the clinic. I I love beyond the guidelines just because I like the thoughtful discussion that, the discussants usually have about something. So I try to do those. And then, um, the American Board of Psychiatry and Neurology, there's some offerings that they have, like, through, like, I think it's called Psychiatry Online or something like that, but I try to listen to those. I like the ones from ACP better because usually there's some questions that I have to answer at the end, and I'm a decent test taker, but I will pay attention if I know there's a test.
That's fair.
And so sometimes when I'm listening to other recordings, if there's not a self-assessment at the end, maybe I don't pay as close of attention as I should.
So you're just swimming in it. You're swimming in it all the time, Vicky. I can
Well,
tell.
I try to keep up, but the other thing, I'm sure you guys both know this, the residents and the medical students keep you on your toes,
Yep.
like, they'll be like, "No, this is the dose of the antibiotics," and I'll be like, Wait, when did this change?" Why,
Yeah.
So, I mean, I think that's the other thing, right? The residents and medical students are always asking questions or putting forth treatment decisions, and
Yeah.
Yeah,
Like,
and having access to the conferences, like the teaching conferences for the residents, I think is a nice benefit of staying,
Mhm.
sticking around here and having a foot in both departments. There's conference every day if you want to go and,
Right.
learn something.
yeah. Speaking of having a foot in both departments, Vicky, you have juggled being the program director for med psych for many years, where you have to like interact with the medicine department and interact with the psychiatry department. How did you manage this? And do you think your training helped you manage both very active departments?
I mean, you know, um, I think it's always trying to be an advocate for the residents and what's going to help them become the best, you know, physicians that they can be. But it's also trying to make sure that they're not getting, like, special treatment, um, but letting the other departments know that it is different what we're expecting of them, and, like, they're going to be here for 5 years, and they might not be able to do every single thing that you want them to do this year. Can they do it next year or the following year?
I always loved seeing you in these meetings, Vicky, because you would always say, "What about the med psych residents?" Like whenever there was and I just loved it because I would always be waiting for you to be like, "And what about the med psych residents?" And you just always said it in this wonderful advocating, like non-confrontational way. And I loved that. Yeah, you set such a great example, such a great role model.
And now Dr. Weber's the program director, and she'll do a fantastic job. And that's I think, she trained here too, and I think that's what you want, right? You want someone better than you, like, stepping into that role, someone, like, with even more skills, so I'm grateful about that.
Yeah, it's a very psychotherapy tone to say, and what about this? And what do you think about this? I'm going to reflect that back on you. What about the med psych residents?
Yeah.
Yeah.
Or who
Yeah,
you might be
luckily,
forgetting.
they didn't get thunder snow too often.
That's
Wasn't
good.
there a show called The Thundercats? Wasn't there like a
There
Thundercat?
was.
Okay, all right. Sorry, I just had to reference that. All right.
Yeah.
Throwback.
So when we think of one of the things that's really apparent on your CV is you have a long list of talks you've been asked to give. I didn't talk to Katie about this, but I was looking through the list and you really are good at naming your talks. And an additional thing that Katie and I might start consulting you on is like, what should we name the talks that we have to give? I'm going to pick two favorites from 2008. And I had to look some of these things up because I'm not the coolest kid. But it was called Horse, Smack, Tar, and Chasing the Dragon.
That's right.
I assume it's about heroin.
It was about
Your
heroin.
Google.
Good job, Katie.
I didn't know the horse one. I had to look up. It's like
Is tar? Smack?
tar.
Yep.
Those are two separate things. Like you can call.
Smack, comma, tar.
Okay,
Yeah.
thank you. I needed the punctuation. Thank you.
Yeah.
Yeah, sorry. And then the other one was from 2019, Too Hard to Swallow, Update in Foreign Body Ingestion. I thought was really good as well. So those are great. But then a lot of your talks, it looks like a big topic that you've been asked to speak on and one that you like to speak on is about dementia and then depression and the crossover between those two things in our aging population. Can you talk a little bit about how you frame that for people, especially caregivers, when you're talking in the community or when you're talking to other caregivers about that population?
Yeah, I mean, I think, I think dementia or major neurocognitive disorder, whatever you want to call it, I think it is hard on patients, but it is really hard on caregivers, right? And I think a lot of times women are the ones that end up providing much of the care for whether it's, parents or spouses. And so I think it's always trying to see like what options are available. There's not good medications for treatment of dementia, right? I mean, one of the big things is like trying to modify risk factors, especially for things like you know, vascular, trying to prevent things like vascular dementia. But even if you have Alzheimer's dementia, doesn't mean you can't get vascular dementia on top of it. So, trying to provide caregiver education about symptoms, like it's not helpful to like argue with someone that has dementia, just like it's not helpful to argue with somebody that has a delusion. It's called a delusion because it's a fixed false belief. You're not going to make it less fixed by arguing about it. And it just because you know, your dad did X, Y, or Z, you know, you can't argue with him and tell him, no, it's not 1984. You could try to distract him. You could move on to something else. The biggest thing I think is safety. And so, um, you know, a lot of a lot of people don't like to have their driving privileges revoked, but like I always tell families, you can put that on me. I'll write the letter to the DOT. I'll tell your loved one that I'm the one that's recommending it. I'm not the driving instructor. So if you disagree with my recommendations, you can go to the DOT and have them do a driving test or something like that. This is my recommendation. I don't think it's safe for you to drive. But I don't want to ruin that relationship that the caregiver has with their loved one by making them the bad guy. I'd rather be the bad guy.
Yeah, that's a challenge. Good tips, though. I love it. Like the distraction, change topic. No, because I mean, we've all seen it, right? Where it's like, no, it's not 1922. Like,
Yeah.
okay. All right. Well, we have a section that we like to call the rapid fire section, Vicki. With
Okay, I'm ready.
questions. Okay, you're ready. If you could go back and meet yourself on your first day of internship, what would you tell yourself?
Don't have you already heard the story that I didn't even think I needed my 4th year of medical school? I was like, "I know everything." And then
No.
and then I had my first day of internship and all heck broke loose.
We
What
need to hear
happened?
more.
Yeah.
I mean, first of all, I was on call. I was on the hemonc unit. Um, there was like a tornado, and all the patients got moved into the hallway. Um,
Was it thunder snow?
it I was, one of the attendings was helping me do intrathecal methotrexate
What?
in the middle of this. The nurses called and asked me to they asked me to come and pronounce a patient, and I'm like, "I don't even know what you're talking about. The person's name is Mr.
Man and
Jones.
wife?
How hard is that to pronounce?" And the nurse is like, "No. He Mr. Jones has died. You need to come and
What?
pronounce him. You need to."
Oh my
And
god.
Oh,
then
wow.
they were just calling about, like, simple stuff like, "Can so and so have Tylenol?" And I'm like, "I have no idea. I don't know." But before I started intern year, I was sure I didn't need that 4th year of medical school. So, if I had to go back and tell myself at the beginning of my first day of intern, it would be, "Don't be so cocky." And at the end of that 24-hour call, well, it turned into 36, but at the end of the call, what I would have told myself was, "Listen to the nurses. They know more than you know." Oh, and I had to cover, what we called the intermediate pulmonary care unit, and they were calling me with asking me how I was supposed to change the ventilator
Ugh.
as an intern.
Oh my gosh.
I'm like, "I don't know. Let me
What do
find my
you think to
senior.
do?
Let me
Yeah.
talk to the respiratory therapist."
What would you
What
suggest?
would yeah, what would you suggest? What would you "Oh, I think we should add a little more PEEP," and yeah.
That sounds great.
I know
Well,
that was
I
supposed to be rapid fire, sorry,
no,
but
No, this is great.
but I think there's conversations about how to, because there's all these conversations about how to increase the doctor workforce in the state of Iowa, and one of them is shortening medical school, right? Is this like, well, maybe we should be putting these folks out in 3 years or 3.5 years, and I, I agree. I felt like I didn't learn much in my 4th year of medical school, but I think if I look back and think, I probably did. I probably like accumulated some just like street smarts maybe
Yeah.
that I didn't have when I left my 3rd year.
yeah, and it gives you the opportunity to, really try, other things. Like I said, I came up here for that sub-internship on the med psych unit. I got some extra ICU months. I mean, I think all of that did help me that
But
Yeah.
not on that first call day.
No.
I'm kidding.
well, I mean, I was very cocky going in. It didn't last very long.
Oh, it is humbling, isn't it?
Mhm. I didn't hear too much of this in your first day, but what's one thing in medicine that grosses you out?
Oh my gosh. One time out there's a lot that grosses me out, but I remember I was a senior on the internal medicine ward on 6 Roy Carver, and we brought in this patient as a transfer that had wet gangrene.
Ugh,
Um,
that sounds like a
and
surgery problem.
Well, so exactly. However, for some reason, he came to 6 Roy Carver, and they had wrapped his feet in, like, chucks and then had, put put, like, tape around him, and I turned to the intern and the medical students, and I said, "Well, we're not gonna be the butt of this old joke about how do you hide a dollar from an internist."
Uh-huh.
I said,
Underdressing.
We're gonna cut these chucks off."
Oh.
So, like, we 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 just cut the tape off, but all this gas had all accumulated, and I thought I was gonna pass out in front of all of them.
That's where you wish you had that N95 and the face shield and the whole COVID
Oh my
getup.
gosh, it was a disaster.
That would have helped.
And then just having my blood drawn, like, I can pass out having my blood drawn.
Interesting.
Wow.
But not
Yeah.
other people. You're not bothered by like
No, I can
poking
do
in
it to other people,
Yeah.
like, I can do procedures, but it was the smell of that wet gangrene after being, like, 2 hours wrapped up in a chucks on the way here. I
Oh,
mean, there was so much g there was so m I mean, there was so much gas and air in there, it was so d and then having my blood drawn.
Okay.
I'm just wiping away the tears. 'Cause even if you would have put some little like Vicks vape
Yeah.
or
No,
nothing would
You
have
know,
helped you.
there's not enough.
hindsight's 2020. I was just like, "We are not gonna be the butt of that joke. We are
Yes.
taking these dressings off before we call the surgeons."
Oh, Vicky, sometimes I am classic for just going a little too far on those
Yeah.
things sometimes. Yeah. Rein it back. Yeah. Okay. Another one. We love to ask women doctors about menopause. Anything you'd like to share with our humongous listening population about menopause?
It gets better?
Ooh. Okay.
Yeah.
That's good. All right.
How about I assume that both sides of your career are talking a lot more about menopause now.
Yep.
What is the psychiatry talk? Because I didn't hear a lot of the medicine talk, but what is the psychiatry like? What's the news? What's the headlines?
Um, well, I'm not we do have, like, some, menopause experts like Christina Koliva, so like if I can't help you, she can help you. But it's just like being aware of being aware of the changes that depressive episodes or mood episodes could be in relationship to this, and really just trying to like staying on top of symptoms and like not waiting too long. Like sometimes I think we are a little complacent and we don't adjust medications as early as we could to help patients feel better sooner.
Yeah.
Yeah. Um, let's see. Next rapid fire question. Any embarrassing situation that you can laugh about now that maybe you couldn't laugh about at the time? Like Katie dropped her pager in the toilet, which
Um,
I tell everybody who will listen about that, but
yeah.
It
I
happens.
mean, I've had my share of embarrassing like situations, like oh my goodness, I've had so many, but in the old CVICU there was like this squawk box where it was this like intercom system that would it went right into the call room, so the nurses, instead of paging you, like they would push the intercom and they would say like, room 8, potassium is 2.8, how much do you want to give? And I mean, I am notorious for not waking up well from sleep, and I think I would tell them something and then I'd have to call them right back and say, "Oh my gosh, I don't even remember what I did."
That's fascinating.
Yeah. They
Oh,
fortunately they don't have that anymore, and nurses, I swear, will not take verbal orders from me anymore, but
yeah. Yeah.
this was in the good
it's not personal. They don't take them from anybody.
yeah, it was the good old days.
Oh, a squawk box, though. I mean, what a way to wake up, right?
Oh,
Like,
Yeah,
yeah. Ugh,
it was like an
ugh,
intercom, and it was right by
ugh.
the bunk bed.
Oh, that's
You
a
didn't even
special
have to
kind of
wake up,
torture.
you could just put your hand over there
Yeah.
and answer it. That was part of the problem, I think.
yeah.
Oh, funny. Favorite candy?
I'm gonna have to go with a Heath bar or a Score bar, whatever's there.
Wait, what was the
That's my
second
favorite
one?
too. Score.
Score, isn't that what it's called?
I
Mhm.
don't know
It's like a
Score
Heath
bar.
bar.
It's like
Oh,
a Heath bar.
okay. So
So
toffee?
it's like
I
yeah,
guess
the toffee.
one of them's in 2 pieces and one of them's in 1 piece.
Yep,
Maybe a score is in 1 piece.
yep, it's
I'm
in one piece.
disappointed that I don't know what a Score bar is. That's
Yeah.
Who
disappointment.
knows? Maybe they don't make them anymore.
No,
I
I
think
bet
they
they
do
do.
it. It is disappointing, Katie.
I know. I'm disappointed in myself, frankly. Yeah,
Mhm.
yeah. Katie, did you have any other rapid fire?
I don't think so. I
All
don't
right,
wanna precipitate any thunder snow.
that's true.
I'm gonna quit while I'm ahead.
You 2 have been on your best behavior, so
Well, Vicki, we do this little ending to the podcast where we talk about historical women in medicine, and I picked someone special for you.
Okay.
Now, I usually don't ask this. Katie usually does pimping of our guests. I usually don't, but I was just going to ask: have you ever heard of Vera French Medical Center?
Yeah,
Have you
over
heard of
in
it?
Davenport, the
Yes.
community health center over there.
Oh, I'm so happy you know about her because I'm highlighting Dr. Vera French. Um, so I actually did a lot of investigative journalism on this. And by a lot, I mean I called my dad because my dad's quite the good resource on all things medical in Davenport. And he put me in connection with Chris McCormick Prees. Now, Chris worked with Dr. Vera French at the Vera French Mental Health Center in Davenport for many years. And she was able to give me some information about Vera French. Now, keep stumbling over her name because a funny thing is, she was my neighbor and she went by Vivi Bates after she had retired. So in my head, I still think of her as Vivi Bates. However, fascinating story about Dr. Vera French. So she grew up in Davenport, and she at first she was born to a very affluent family. And she was born in 1921. And then she went to St. Catherine's School and Bryn Mawr College, and then earned a master's degree and a PhD in psychology from Radcliffe. And in her like future paperwork it says Harvard, and so I was kind of confused about this, but Chris tipped me off and I did some investigations that at the time Harvard did not accept women. However, in World War II, they allowed like Radcliffe students, women, to come to Harvard to take classes, and they did all of their classwork there, and then were given a degree from Radcliffe. But then back in 1963, they kind of reverted and said, "Hey, we'll award those women degrees from Harvard." So she had her PhD and master's in psychology from Harvard, and then worked at Swarthmore. I just like saying Swarthmore
Swarthmore.
as an assistant professor in psychology in 1944. And according to Chris, this kind of gave her the chutzpah, is the word that Chris used, to then say, I can sit at the table, like I can go on to become a medical doctor. And that's what she did. So she earned her MD from Columbia College of Physicians and Surgeons, and then did her internship and residency here at the University of Iowa. She then did private practice in Davenport from 1955 to 1961, and she served as the staff of the Medical Health Center of Scott County, associate director, and then became the director of kind of the Medical Health Center of Scott County. And she held that until 1980. And then later on, the facility was renamed to Vera French Community Mental Health Center. And I just thought it was really amazing hearing about Dr. French because Chris just said that she didn't have to work. She came from a very wealthy family,
Mhm.
and yet she felt called to give back to her community. And she really felt the need to make psychiatry transparent to the community and to have the community see what they were doing and also see that it's their people, it's their family, it's their friends, it's their community that are being helped within these psychiatry clinics. And so she actually designed the new building for the Vera French Mental Health Center and made it in a figure eight and had open courtyards on both sides so that the community could always see in to kind of increase
Nice.
transparency and increase knowledge about mental health. And she raised $400,000, and then a federal grant helped with another $400,000 to build that. And I mean, she just sounds like a real trailblazer in medicine and just a wonderful person. And even to this day, when they designed buildings, they made sure that they have floor to ceiling windows so that everything is open to everybody and every patient has a window to the world. And I thought that was just pretty wonderful, and just wanted to call attention to to her. And I will say, after talking to Chris for 15 minutes, I was like, I want to bring her on this podcast
You
too,
should.
because she's an ARNP, she's clinical director, directed all these, programs at Vera French. So just so many wonderful women around to highlight. And I thought of her with all of your psychiatry background. So yeah, and I want to say thanks to Chris and to my wonderful dad for always answering my phone calls and my very strange questions.
Yeah.
And he's like, podcast? So Vicki, huge thanks for spending time with us today. We love chatting with you.
You're welcome. Thanks for having me. I appreciate it.